I should also say, sort of from the start, that all of the work I'm going to talk about, all of the ideas, some I've developed in connection with Thomas Flo, who's professor at Aalborg University in Denmark. Uh, Now, what I'm going to talk about is this particular issue, which is not an issue which is central to your project, but I think an issue which will become important in the future. Uh, and that is essentially that at the end of clinical trials, there will be data and or biological samples which are stored and which might become useful for future research, either just that data set or linked up to other data sets or merged to other data sets. And they might become useful both for, I'll now call it the sponsoring firm, uh, sort of irrespective of whether it's a firm or someone else who's running a trial, and it might become useful for outside researchers. Uh, and I think this is partly going to be driven by developments broadly within open science. We've also already seen uh, moves towards people having to, or being strongly urged to uh, share anonymized data sets, but I think that in the future we will also see moves to people and access being demanded for linkage to other data sets, which maybe uh, raises further problems. So I'll simply call this sort of the secondary use problem. Uh, so it occurs in what I'm going to talk about essentially after the end of the study itself. Now, the secondary use problem has a number of possible solutions, and this is not an exhaustive list. Uh, we might try to solve it with simply having broad consent as part of the consent to the study, the initial consent to the study. We might have dynamic consent. Uh, we might have the idea I'm going to try to sell you, which is meta consent, or we might simply say this kind of secondary use should be possible without consent. And coming originally from Denmark and following the Danish position, of course, in Denmark, the sort of underlying position about the use of clinical data for research is that that can go on without people's consent. Uh, so it's a possible solution, but not one I will talk about today. Now, why is broad consent not the solution? Well, there are several reasons. The first, which I haven't listed on the slide, is that at the moment where people consent to a clinical trial, especially if they have a significant health problem, uh, the part of the consent process where we are explaining to them what we might do with their data or samples in the future is not likely to interest them very much. They'll be focused on the actual trial they're being asked to participate in. They'll be focused on their particular health problem. So even though we could get broad consent, it is ethically questionable whether that consent would be valid, because it's like sort of the studies you have probably seen where people are willing to sort of give up their firstborn for Wi-Fi access in the cafe because their main interest is Wi-Fi access, and they simply don't read or take in all the terms and conditions. There's also another issue around broad consent, and that is that it has what Thomas and I have called an expiry problem. People consent to what they understand at the time they consent. And that creates two problems. One is that consent is what philosophers would call referentially opaque. Uh, so we can't necessarily extrapolate from what someone has consented to some other consent. So the standard example is that the fact that I have consented to someone using my tissues or the tissues of my dead child doesn't mean that researchers can then remove whole organs from my dead child, even though whole organs are tissue. There's also the problem that over time it becomes more uncertain what the original consent actually meant. So, for instance, if someone consents to future use for health research and had done that 20 years ago, well, how did they consider health research at that moment? So a recent example is that some American researchers did a study which was published in Science on the genetic basis for same-sex sexual activity, and used a lot of the main part of their data came from UK Biobank, which has broad consent for health-related research, but was what the American researchers did health-related research or not? And was it what the participants of UK Biobank at the time when they consented would have seen as health-related research? Now we can solve this expiry problem of broad consent by making the consent broader and broader, making it more unspecific. But eventually this means that it collapses broad consent into blanket consent, sort of the idea that people simply consent to any further possible use of their data. And from an ethical point of view, it is questionable whether such blanket consents are really valid as informed consents. Another solution is dynamic consent, which essentially takes as its departure the idea that we can't really rely on broad consents. We need a dynamic consent solution where we can, in the future, ask people for consent to specific new things that we want to do. And this is, of course, the idea which has been developed initially by Jane Kay and her group in Oxford. And this is, in principle, I think, a very good idea. The problem, I think, is that implementing it trial by trial is not an optimal solution to the secondary use problem. First of all, it means that there will be implementation costs in every trial. It also means that if a researcher in the future needs data from more than one trial, we will have potential inconsistencies between the dynamic consent implementations, the way people ask about dynamic consent, the particular consent options they have, which may make it difficult to do the research. It also means that there are very significant transaction costs for researchers which are external to these trials, in that they will have to negotiate with each trial about access, about the particular consent requests sent out through the dynamic consent platform, and so on. And there's a potential for overload and consent fatigue, especially in patient groups which have chronic conditions and which are participating in multiple trials. So they might get dynamic consent requests from each of the trials they participated in, and that might create a problem. So the solution that Thomas Flo and I are suggesting is essentially a solution which sort of tries to, well, it tries to solve the problem for trials, but it also tries to solve the problem we have in use of secondary use of data and samples which are collected as part of normal everyday clinical activities. And the basic idea is that we should ask people what their consent preferences are in relation to the use of their health and then non-health data for research. And as we know from countries like Denmark or the other Nordic countries, the ability to link health and non-health data for research is very important and becomes increasingly important. People can then state their preferences, and that will then govern when and how they'll be asked for consent in the future. And 20 years ago, we wouldn't be able to do this. Now we can do it because of the developments in ICT, the same developments which makes it possible to extract, collect, link, and use the data now also makes it possible to run a meta-consent system and to get people's preferences and tailor their future consents. And we have shown in some of our papers how this could be implemented in a country like Denmark or in Norway or Sweden or other reasonably well-functioning administrative structures. So the idea is that you present people with a set of choices, and of course you would have to do quite a lot of prior research about exactly what choices it is people would have to would like to make. So sort of this is just a conceptual model, not sort of we are not wedded to these being the choices that should actually be there. So you have a type of consent that people can choose. You have for type of data. You have type of context, sort of who are going to use these things and for what, and people can simply state their preferences up front. So someone could say, give blanket consent if that's what they want. They could give broad consent for broader categories of research. So they could say, no, I want to be contacted for every new use of my data. Now, the implementation structure would look something like this, where you have the patient on the left-hand side of the screen, the researchers on the right-hand side, and the meta-consent system in the middle. And this is probably how it would look for Denmark if it was implemented, that the patient or participant, citizen, make their meta choices, which are stored in the meta-consent hub. At some later point, researchers want access to certain data. They specify what data, formulate a consent request, which then goes here and goes out to the patients, who can then, those who want that kind of consent request can put it back. The data will then be extracted, linked if possible, if needed, and sent back to the researchers. And the researchers can then have to feedback sort of that data was used in this particular project. Now, of course, this could be done in a more decentralized way, where what the meta consent system does is simply provide a set of permissions to researchers to access directly particular data sources. Now we have done this, we have done the front end as a sort of demonstration in a smartphone app in Denmark. Obviously, all the text would be in Danish, but that wouldn't be very helpful for you. And we have shown that people are willing to do this and that their choices are not particularly restrictive, because one of the worries that researchers often raise is that the choices would be very restrictive, but it turns out that at least in the Danish population, the choices people make will not particularly restrict. So essentially, people are here asked for the consent types with a short explanation. They can have further explanations if they want. Then asked to make, for instance, here choices about what data types they're willing and what consent type they want for a particular data type. So why do we think that meta consent can solve the secondary use problem? Well, we think it's a good solution because it's general and not linked to any specific research project or trial, and it's not linked either to any particular data source. It's not specific for health data, but will allow linkage to things like employment data, social data, and other things. On the researcher side, it has low transaction costs, and it's dynamic in the sense that citizens can state and modify their consent preferences at any time they choose. So they could change them in response to something specific that has happened to them, some specific use of their data. They could change them in response to changes in sort of their general view of the importance of medical research, and so on. And the architecture is flexible for communicating consent requests from researchers to potential participants and communicating consent responses the other way. So we think this, for various reasons, is a better solution than broad consent or dynamic, sort of more specific dynamic consent to the secondary use of data. And if you want to read more about it, here are a number of our papers on this and a report from the Danish Council of Ethics, which endorses the model by the majority of the council.